Question 1. A critical care nurse is managing a patient with septic shock. Which of the following hemodynamic parameters is the most appropriate initial goal for mean arterial pressure, MAP, after fluid resuscitation? A. MAP greater than 50 mm of mercury. B. MAP greater than 65 mm of mercury. C. MAP greater than 75 mm of mercury. D. MAP greater than 80 mm of mercury. Answer, B. MAP greater than 65 mm of mercury. This question tests knowledge of initial management goals for septic shock, specifically concerning mean arterial pressure, MAP. The keyword initial goal highlights the immediate target after fluid resuscitation. For patients in septic shock, the goal is to maintain a MAP greater than 65 mm of mercury to ensure adequate organ perfusion while avoiding excessive vasoconstriction that could worsen tissue ischemia. Achieving this MAP helps to restore blood flow to vital organs, preventing further organ dysfunction. For example, if a patient's MAP is 58 mm of mercury despite fluid boluses, the nurse should anticipate starting vasopressors to reach the target of greater than 65 mm of mercury. Remember, maintaining a MAP of at least 65 mm of mercury is crucial for perfusion in shock states. Question 2. A patient on mechanical ventilation for acute respiratory distress syndrome, ARDS, has progressively worsening hypoxemia. The nurse notes peak inspiratory pressures are increasing. Which intervention should the nurse anticipate next? A. Administering a bronchodilator. B. Increasing the fraction of inspired oxygen, FiO2, to 100%. C. Initiating prone positioning. D. Suctioning the endotracheal tube. Answer, C. Initiating prone positioning. This question focuses on the management of acute respiratory distress syndrome, ARDS, and worsening hypoxemia, with worsening hypoxemia and ARDS being key clues. For patients with ARDS and refractory hypoxemia, prone positioning is a well-established intervention that improves oxygenation by redistributing ventilation and perfusion, opening previously collapsed lung units, and improving secretion clearance. While increasing FiO2 may be a temporary measure, prone positioning addresses the underlying pathophysiology more effectively by improving V/Q mismatch. Imagine turning a patient on their stomach to allow the heavier, consolidated lung tissue to fall forward, opening up the less affected dorsal areas for better gas exchange. Implementing prone positioning can significantly improve oxygenation and lung mechanics in these critical patients. Question 3. A patient admitted with an ST elevation myocardial infarction, STEMI, develops sudden onset of chest pain, dyspnea, and muffled heart sounds. The nurse notes a significant drop in blood pressure and jugular vein distension. Which complication is the patient most likely experiencing? A. Cardiogenic shock. B. Pulmonary embolism. C. Cardiac tamponade. D. Ventricular fibrillation. Answer, C. Cardiac tamponade. This question assesses the nurse's ability to identify complications of myocardial infarction, specifically focusing on a triad of classic signs. The keywords sudden onset of chest pain, dyspnea, muffled heart sounds, drop in blood pressure, and jugular vein distension describe Beck's triad, which is a hallmark of cardiac tamponade. Cardiac tamponade is a life-threatening condition where fluid accumulates in the pericardial sac, compressing the heart and impairing its ability to fill and pump blood effectively. This often results from myocardial rupture post-MI. Recognizing Beck's triad demands immediate intervention, such as pericardiocentesis, to relieve the pressure on the heart. Question 4. A patient's arterial blood gas, ABG, results are pH 7, 28, PaCO 2 55 mm of mercury, HCO 3 24 milliequivalent/L, and PaO 2 78 mm of mercury. Which acid-base imbalance does this indicate? A. Metabolic acidosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Respiratory alkalosis. Answer: C. Respiratory acidosis. This question tests the interpretation of arterial blood gas, ABG, results to identify an acid-base imbalance. The key values to analyze are pH, PaCO 2, and HCO3. A pH of 7.28 indicates acidosis, acidity. A PaCO 2 of 55 mm of mercury, normal is 35 to 45 mm of mercury, indicates hypercapnia or respiratory contribution to acidity, and an HCO3 of 24 milliequivalent/L, normal is 22 to 26 milliequivalent/L, is within the normal range, meaning no significant metabolic compensation or primary metabolic issue. Therefore, the low pH with an elevated PaCO 2 and normal HCO3 points directly to an uncompensated respiratory acidosis. Understanding the normal ranges for ABG values is essential for accurately diagnosing these imbalances. Question 5. A patient is receiving a continuous infusion of norepinephrine for distributive shock. Which assessment finding indicates a potential adverse effect requiring immediate intervention? A. Blood pressure 100/60 mmHg. B. Heart rate 90 beats/min. C. Capillary refill time of 5 seconds. D. Urine output 40 milliliters per hour. Answer: C. Capillary refill time of 5 seconds. This question addresses the monitoring of patients receiving vasopressor therapy, specifically norepinephrine, and recognizing adverse effects. The key clue, potential adverse effect requiring immediate intervention, directs you to identify a sign of inadequate tissue perfusion or excessive vasoconstriction. A capillary refill time of 5 seconds is prolonged, normal is less than 3 seconds, indicating poor peripheral perfusion, which can be a serious side effect of vasopressors like norepinephrine if the dose is too high or causing excessive vasoconstriction. While a blood pressure of 100/60 and heart rate of 90 may be acceptable or improving, and a urine output of 40 milliliters per hour is generally adequate, severely diminished peripheral perfusion suggests potential tissue ischemia and necrosis, especially in digits. Always assess for adequate peripheral perfusion when administering vasopressors to ensure benefits outweigh risks. Question 6. The nurse is caring for a patient with diabetic ketoacidosis, DKA. Which laboratory finding is the most critical for the nurse to monitor initially as insulin therapy begins? A. Serum glucose. B. Serum potassium. C. Arterial blood gases. D. Serum sodium. Answer: B. Serum potassium. This question focuses on the initial management and critical monitoring in diabetic ketoacidosis, DKA, treatment. While all listed lab values are important, initially as insulin therapy begins is the crucial clue. Insulin therapy shifts potassium from the extracellular space back into the cells, which can rapidly lead to life-threatening hypokalemia, even if the initial serum potassium level was normal or elevated. Therefore, close monitoring of serum potassium levels and prompt replacement, often before insulin or concurrently, is paramount to prevent cardiac arrhythmias. For example, if a patient's potassium drops to 2.8 milliequivalent/L after starting insulin, immediate potassium supplementation is necessary to prevent dysrhythmias. Always remember to prioritize potassium monitoring and replacement during DKA treatment with insulin. Question 7. A critical care nurse is assessing a patient with a traumatic brain injury. Which of the following is the earliest and most sensitive indicator of increased intracranial pressure, ICP? A. Cushing's triad, bradycardia, hypertension, irregular respirations. B. Fixed and dilated pupils. C. A change in the level of consciousness. D. Decerebrate posturing. Answer, C. A change in the level of consciousness. This question tests knowledge of neurological assessment and the early signs of increased intracranial pressure, ICP. The keywords earliest and most sensitive indicator are vital clues. A subtle change in the patient's level of consciousness, LOC, such as restlessness, confusion, or difficulty arousing, is often the first observable sign of increasing ICP because the cerebrum is highly sensitive to pressure changes. Cushing's triad, fixed pupils, and decerebrate posturing are all late and ominous signs, indicating severe brainstem compression. Observing even slight changes in a patient's alertness or orientation is paramount for timely intervention to prevent further neurological damage. Question 8. A patient is admitted to the critical care unit with severe pancreatitis. The nurse should be most vigilant for which life-threatening complication? A. Hyperglycemia. B. Hypocalcemia. C. Acute respiratory distress syndrome, ARDS. D. Pancreatic pseudocyst formation. Answer, C. Acute respiratory distress syndrome, ARDS. This question asks about the most life-threatening complication of severe pancreatitis. While hyperglycemia, hypocalcemia, and pseudocyst formation are common issues with pancreatitis, life-threatening is the crucial keyword. Acute respiratory distress syndrome, ARDS, is a severe pulmonary complication that can develop rapidly in pancreatitis due to systemic inflammatory response syndrome, SIRS, leading to significant morbidity and mortality. The inflammatory mediators released from the damaged pancreas can cause widespread capillary leakage, including in the lungs, leading to acute lung injury and ARDS. For example, a patient with pancreatitis might suddenly become severely dyspneic, requiring mechanical ventilation. Always closely monitor respiratory status in pancreatitis patients due to the high risk of ARDS. Question 9. A nurse is caring for a patient receiving continuous renal replacement therapy, CRRT. What is the primary advantage of CRRT over intermittent hemodialysis for a critically ill patient with hemodynamic instability? A. More rapid removal of fluid and solutes. B. Less need for anticoagulation. C. Better preservation of cardiovascular stability. D. Lower risk of infection. Answer, C. Better preservation of cardiovascular stability. This question assesses the understanding of continuous renal replacement therapy, CRRT, and its benefits, especially for critically ill patients. The keywords primary advantage and hemodynamic instability are key clues. CRRT removes fluid and solutes slowly and continuously over 24 hours, which prevents rapid fluid shifts and minimizes the risk of hypotension, a common complication with the faster fluid removal rates of intermittent hemodialysis. This gentle approach helps to maintain blood pressure and cardiac output, making it the preferred method for patients who are too unstable to tolerate the acute changes associated with traditional hemodialysis. Imagine gradually siphoning off fluid versus quickly draining it. The gradual method is less disruptive to the patient's delicate circulatory balance. Question 10. A patient presents with crushing substernal chest pain radiating to the left arm, diaphoresis, and shortness of breath. Which initial diagnostic test is most important for the nurse to anticipate? A. Chest X-ray. B. Troponin levels. C. Electrocardiogram, ECG. D. Complete blood count, CBC. Answer, C. Electrocardiogram, ECG. This question describes classic symptoms of acute coronary syndrome, and the most important initial diagnostic test is the key. An electrocardiogram, ECG, provides immediate information about cardiac electrical activity, allowing for rapid identification of ST elevation myocardial infarction, STEMI, or other acute ischemic changes, which guides immediate treatment decisions such as reperfusion therapy. While troponin levels are crucial for confirming cardiac injury and a chest X-ray might rule out other causes of chest pain, the ECG offers the fastest diagnostic information to direct life-saving interventions in a suspected myocardial infarction. Obtaining a 12-lead ECG within 10 minutes of presentation for chest pain is a critical benchmark in emergency care. Question 11. The nurse is caring for a patient who develops new-onset atrial fibrillation with a rapid ventricular response, RVR, and hypotension. Which intervention should the nurse anticipate immediately? A. Administering a beta blocker intravenously. B. Preparing for synchronized cardioversion. C. Initiating a heparin drip. D. Administering adenosine intravenously. Answer, B. Preparing for synchronized cardioversion. This question tests the management of a cardiac arrhythmia, specifically atrial fibrillation with rapid ventricular response, RVR, compounded by a critical hemodynamic finding. The keywords new-onset atrial fibrillation with a rapid ventricular response combined with hypotension are crucial. When a patient with a tachyarrhythmia is hemodynamically unstable, for example, hypotensive, showing signs of shock, acute altered mental status, immediate synchronized cardioversion is the treatment of choice to restore a stable rhythm and prevent further hemodynamic compromise. Administering medications like beta blockers or adenosine would be too slow and potentially worsen the instability. Imagine a patient whose blood pressure is plummeting due to their fast heart rate. Electrical cardioversion can quickly restore a more effective rhythm. Question 12. A critical care nurse is assessing a patient post-stroke. Which assessment finding requires immediate notification of the healthcare provider? A. Unilateral facial droop. B. Sudden onset of a severe headache. C. Difficulty swallowing liquids. D. Weakness in the right arm and leg. Answer, B. Sudden onset of a severe headache. This question focuses on recognizing a critical change in a post-stroke patient. While unilateral facial droop, difficulty swallowing, and weakness are common stroke symptoms, the sudden onset of a severe headache is the key clue for an emergent complication. In a post-stroke patient, a new, sudden, severe headache can indicate hemorrhagic transformation of an ischemic stroke, rebleeding of a hemorrhagic stroke, or an acute increase in intracranial pressure, all of which are life-threatening and require immediate evaluation and intervention. This symptom signals a potentially acute and dangerous change in the patient's neurological status. Question 13. A patient with severe sepsis is receiving broad-spectrum antibiotics. The nurse notices the patient's platelet count is decreasing, D-dimer is significantly elevated, and there is new onset of oozing from 4 sites. Which hematologic complication is most likely occurring? A. Immune thrombocytopenic purpura, IDP. B. Heparin-induced thrombocytopenia, HIT. C. Disseminated intravascular coagulation, DIC. D. Thrombotic thrombocytopenic purpura, TTP. Answer, C. Disseminated intravascular coagulation, DIC. This question tests the recognition of a complex hematologic disorder common in critical illness. The keywords severe sepsis, decreasing platelet count, significantly elevated D-dimer, and oozing from 4 sites together point strongly to disseminated intravascular coagulation, DIC. DIC is a life-threatening condition characterized by widespread activation of the coagulation system, leading to both excessive clotting, which consumes platelets and clotting factors, leading to elevated D-dimer, and paradoxical bleeding. Sepsis is a common trigger for DIC. For example, a patient with sepsis might develop widespread petechiae and ecchymosis while simultaneously experiencing organ damage from microclots. Recognizing these signs quickly is crucial for managing this severe complication. Question 14. An adult patient is admitted with syndrome of inappropriate antidiuretic hormone, SIAD. The nurse should anticipate which of the following fluid and electrolyte imbalances? A. Hypernatremia and fluid deficit. B. Hyponatremia and fluid overload. C. Hyperkalemia and fluid deficit. D. Hypokalemia and fluid overload. Answer, B. Hyponatremia and fluid overload. This question assesses knowledge of the key fluid and electrolyte imbalances associated with syndrome of inappropriate antidiuretic hormone, SIAD. The concept of SIAD involves excessive release of antidiuretic hormone, ADH, even when serum osmolality is low, leading to increased water reabsorption in the kidneys. This results in dilutional hyponatremia, low sodium due to excess water, and fluid overload, excess free water in the body. The body retains water, diluting the sodium concentration, but the overall body fluid status is one of volume excess. Therefore, the nurse should anticipate both hyponatremia and fluid overload. Question 15. The nurse is caring for a patient who received a blood transfusion 30 minutes ago and is now experiencing a sudden onset of fever, chills, back pain, and dark urine. What is the immediate nursing action? A. Administer antipyretics and continue the transfusion at a slower rate. B. Stop the transfusion immediately and keep the 4-line open with normal saline. C. Document the findings and obtain vital signs hourly. D. Obtain an order for a new blood product and restart the transfusion. Answer, B. Stop the transfusion immediately and keep the 4-line open with normal saline. This question describes classic signs of an acute hemolytic transfusion reaction, and immediate nursing action is the crucial keyword. When a patient develops symptoms like fever, chills, back pain, and dark urine after a blood transfusion, the nurse must immediately stop the transfusion to prevent further complications from incompatible blood. The 4-line should be kept open with normal saline to maintain venous access and support blood pressure, while notifying the blood bank and healthcare provider, and following institution protocol for collecting blood and urine samples. Continuing the transfusion or delaying action could have life-threatening consequences. This is a critical safety intervention that every nurse must know. Question 16. A patient with a history of heart failure is admitted with acute decompensated heart failure. The nurse anticipates administering which medication to reduce preload and afterload? A. Digoxin. B. Furosemide. C. Nitroprusside. D. Metoprolol. Answer, C. Nitroprusside. This question focuses on the pharmacologic management of acute decompensated heart failure, specifically targeting both preload and afterload reduction. The key is to identify a medication that has both venodilating, preload reduction, and arterial dilating, afterload reduction, effects. Nitroprusside is a potent arterial and venous vasodilator that rapidly reduces both preload and afterload, significantly improving cardiac output and decreasing pulmonary congestion in acute decompensated heart failure. While furosemide reduces preload by diuresis and metoprolol is a beta blocker, nitroprusside directly addresses both factors acutely, making it highly effective in this critical situation. Question 17. A nurse is preparing to administer intravenous potassium chloride to a patient with severe hypokalemia. Which is the safest and most appropriate method of administration in a critical care setting? A. Rapid 4 bolus over 5 minutes. B. Administering undiluted through a peripheral 4. C. Infusing through a central line no faster than 10 milliequivalent/hour. D. Adding to a dextrose 5% in water, D5W, solution as the primary 4 fluid. Answer, C. Infusing through a central line no faster than 10 milliequivalent/hour. This question addresses the safe administration of intravenous potassium chloride, a high-alert medication, especially for severe hypokalemia in a critical care setting. Intravenous potassium chloride must always be diluted and administered slowly to prevent potentially fatal cardiac arrhythmias and local irritation. The maximum recommended infusion rate for potassium in a non-emergent situation in a peripheral line is typically 10 milliequivalent/hour, and even this can cause pain. A central line is often preferred for higher concentrations or faster rates, if clinically indicated and with continuous cardiac monitoring, but the maximum rate of 10 milliequivalent/hour still generally applies to prevent rapid shifts that can cause cardiac arrest. Rapid bolus, undiluted administration, or mixing with D5W, which can cause intracellular potassium shift, are all dangerous practices. Always remember the mantra. Never push potassium. Question 18. A critical care nurse is performing a neurological assessment on a patient suspected of having a subarachnoid hemorrhage. Which assessment finding is most indicative of this condition? A. Unilateral weakness. B. Nuchal rigidity. C. Absence of deep tendon reflexes. D. Slurred speech. Answer, B. Nuchal rigidity. This question focuses on the specific signs associated with a subarachnoid hemorrhage, SAH. The keyword most indicative directs you to the classic symptom. Nuchal rigidity, or stiffness of the neck, is a hallmark sign of meningeal irritation, which commonly occurs when blood irritates the meninges after a subarachnoid hemorrhage. While unilateral weakness and slurred speech can be seen in various neurological conditions including stroke, and absent deep tendon reflexes are not typical, nuchal rigidity is a strong indicator of meningeal irritation from blood in the subarachnoid space. Always assess for this specific sign when SAH is suspected. Question 19. A patient is intubated and mechanically ventilated. The high-pressure alarm frequently sounds. What is the nurse's priority action? A. Sedate the patient. B. Assess the patient and the ventilator circuit. C. Increase the set tidal volume. D. Call the respiratory therapist immediately. Answer, B. Assess the patient and the ventilator circuit. This question addresses a common ventilator alarm, the high-pressure alarm, and the priority action required. When a ventilator alarm sounds, the immediate priority is always to assess the patient first, then the equipment. High-pressure alarms indicate increased airway resistance or decreased lung compliance, which could be due to patient-related factors, e.g., coughing, biting the tube, secretions, bronchospasm, pneumothorax, or equipment-related issues, e.g., kink tubing, water in tubing, ventilator malfunction. Systematically checking the patient's breathing, breath sounds, and tube placement, followed by an inspection of the ventilator circuit, helps quickly identify and resolve the problem, potentially preventing harm. Question 20. A patient in the critical care unit expresses a desire to discontinue life support. The family vehemently disagrees, stating they believe the patient would want to continue treatment. What is the nurse's primary role in this ethical dilemma? A. Encourage the family to agree with the patient's decision. B. Advocate for the patient's right to self-determination. C. Support the family's wishes to continue treatment. D. Consult with the hospital's legal department immediately. Answer: B. Advocate for the patient's right to self-determination. This question presents a common ethical dilemma in critical care, highlighting a conflict between patient autonomy and family wishes. The primary role of the nurse in such a situation is to advocate for the patient's right to self-determination, also known as autonomy, assuming the patient has decision-making capacity. If the patient is competent to make their own choices, their wishes regarding medical treatment, including discontinuation of life support, should be respected and upheld, even if family members disagree. The nurse should facilitate communication between the patient, family, and healthcare team, ensuring the patient's voice is heard and understood, and potentially involve an ethics committee. Question 21. A critical care nurse is monitoring a patient's urine output following an acute kidney injury, AKI. The patient is currently producing 50 milliliters of urine per hour after a period of anuria. In which phase of AKI is this patient most likely? A. Onset phase. B. Oliguric phase. C. Diuretic phase. D. Recovery phase. Answer: C. Diuretic phase. This question tests knowledge of the phases of acute kidney injury, AKI. The key clues are producing 50 milliliters of urine per hour after a period of anuria. This scenario describes the diuretic phase of AKI, where the kidneys begin to excrete urine again, often in large quantities, as the nephrons recover their ability to filter and excrete waste products. Initially, output may be low, but as recovery progresses, it can increase significantly. The oliguric phase would be characterized by very low urine output, e.g., less than 400 milliliters per 24 hours, and the onset phase is the initial injury, while the recovery phase represents full restoration of kidney function. Recognizing this transition is crucial for managing fluid and electrolyte balance during recovery. Question 22. A 68-year-old patient with a history of hypertension is admitted with altered mental status. Laboratory results reveal serum sodium 120 milliequivalent/L, and urine osmolality is elevated. Physical examination shows mild edema. These findings are most consistent with which condition? A. Diabetes insipidus. B. Hyperosmolar hyperglycemic state, HHS. C. Syndrome of inappropriate antidiuretic hormone, SIAD. D. Addisonian crisis. Answer: C. Syndrome of inappropriate antidiuretic hormone, SIAD. This question requires linking specific laboratory and physical findings to an endocrine disorder. The key clues are serum sodium 120 milliequivalent/L, hyponatremia, urine osmolality is elevated, concentrated urine, and mild edema, fluid retention. These findings are classic for syndrome of inappropriate antidiuretic hormone, SIAD, where excessive ADH leads to free water retention, diluting serum sodium and causing concentrated urine despite low serum osmolality. Diabetes insipidus would present with hypernatremia and dilute urine, while HHS would involve extremely high glucose. Recognizing this constellation of symptoms is essential for appropriate management of fluid and electrolyte balance. Question 23. The nurse is caring for a patient experiencing a severe gastrointestinal bleed. Which assessment finding is the most reliable indicator of effective fluid resuscitation? A. Decreased heart rate. B. Increased blood pressure. C. Improved urine output. D. Absence of orthostatic hypotension. Answer: C. Improved urine output. This question focuses on monitoring the effectiveness of fluid resuscitation in a patient with a severe gastrointestinal bleed. While decreased heart rate, increased blood pressure, and absence of orthostatic hypotension are all positive signs, improved urine output is the most reliable and sensitive indicator of adequate end organ perfusion, particularly to the kidneys, which are highly sensitive to hypoperfusion. A urine output of at least 0.5 ml/kg/hour, or generally greater than 30 milliliters per hour in adults, suggests that vital organs are receiving sufficient blood flow and oxygenation. If urine output remains low despite fluid administration, it indicates ongoing hypoperfusion and inadequate resuscitation. Question 24. A critical care nurse is assessing a patient with a tension pneumothorax. Which clinical finding is a late, but critical, sign of this condition? A. Tracheal deviation to the unaffected side. B. Sudden onset of sharp chest pain. C. Dyspnea and tachypnea. D. Absent breath sounds on the affected side. Answer: A. Tracheal deviation to the unaffected side. This question tests the understanding of a life-threatening respiratory emergency, a tension pneumothorax, and its signs. While sharp chest pain, dyspnea, tachypnea, and absent breath sounds are common signs, tracheal deviation to the unaffected side is a critical, late sign that indicates significant mediastinal shift and impending cardiovascular collapse due to extreme intrathoracic pressure. This finding signifies severe compromise of both respiratory and circulatory function, requiring immediate needle decompression. Observing the trachea shifted away from the side of the collapsed lung confirms the severity of the tension pneumothorax. Question 25. A patient undergoing aggressive fluid resuscitation for hypovolemic shock develops crackles in the lungs and increasing oxygen requirements. Which acid-base imbalance is this patient most at risk for developing due to the aggressive fluid therapy? A. Respiratory acidosis. B. Metabolic alkalosis. C. Respiratory alkalosis. D. Metabolic acidosis. Answer: D. Metabolic acidosis. This question assesses the risk of acid-base imbalances related to aggressive fluid resuscitation in hypovolemic shock. While fluid overload, indicated by crackles and increased oxygen requirements, is a direct complication of aggressive fluid resuscitation, the specific acid-base imbalance it can lead to is metabolic acidosis. Aggressive administration of large volumes of normal saline, which has a high chloride content, can result in hyperchloremic metabolic acidosis. This happens because the excess chloride competes with bicarbonate, leading to a decrease in serum bicarbonate and a subsequent drop in pH. Monitoring for this complication is important as it can further compromise organ function in an already critically ill patient.